Welcome to our webinar today, Hands-on Justice. It's our first webinar. Oh, I'm sorry, I've just got a sign that people can't hear me. So, Rupert, you can hear, can't you?
Yeah, I can hear you well, actually.
Wonderful. And just going up to the top in the chat, I'm going to just put in, someone has just mentioned they can't hear, so I'm just going to ask the attendees. Ben can hear me fine. So I think it might be just this particular person's laptop itself. So I'll continue. So just to introduce, hello again. We're here with Mr. Wharton, orthopedic trauma, consultant trauma and orthopedic surgeon specialising in hand and wrist. And we're here in conjunction with INNEG to run a webinar today on hand and wrist, and to hear what Mr. Wharton has to present on the matter. Just to advise, there will be a Q&A function afterwards. So at the top, there is the Q&A box or the chat box, and either if you're able to put your comments throughout the presentation in there, and at the end, we will ask as many as we can to Mr. Wharton. Anything which isn't asked during the time will be taken away and we can respond afterwards to you. And lastly, of course, this webinar is recorded, and we will be able to facilitate and provide you with a recording following the event for you and for any other colleagues to watch. We'll be uploading it to YouTube as well. And just lastly, for those who haven't perhaps come in touch and been in touch with us or know about INNEG before, INNEG are a specialist provider. We are able to source experts across our database for any type of medical expert report you require, down to very niche specialisms, both across personal injury, serious injury, and clinical negligence, as well as other areas of criminal and family matters. So if you may have a requirement, whether it's on a regular or an occasional basis, you are welcome to reach out to us and we will try and support you in any way we can. That aside, I don't want to hold you up any further, so I will pass across to Mr. Wharton to present, and I look forward to taking your questions afterwards. Thank you.
That's brilliant. Well, thank you, Leo. I'm conscious that there's a lot of sport and politics news going on at the moment, so I'm grateful to you all for attending. And I appreciate that your lunch break is very valuable, so I'm grateful in that regard. And I appreciate also that I look like I'm in prison at the moment with my backdrop, and I assure you that I am a free man, but the state of our office is such that it was advantageous to present in this manner. So I'm Rupert Wharton. I'm a consultant trauma and orthopedic surgeon. I work in central and southwest London, and I have an NHS practice covering the generality of trauma, hand trauma, and elective hand and wrist problems. And I have a private practice which covers both trauma and elective conditions affecting the hand and wrist. I work with a group called Grosvenor Orthopaedics, and I'm conscious as I go through this process of increasing years as a consultant that in any field of work, nobody is ever the finished article. And so I remain grateful to two people in particular who have mentored me through both my clinical training and my medical legal training. And any of you involved in hand and wrist personal injury may recognize Mr. Mike Hayton in the image on the left, who works in Wrightington and in Manchester, and Mr. Dan Armstrong in the image on the right, who works in Derby and Nottingham, both of whom I remain grateful to for their ongoing mentorship. So what are we going to talk about today? Well, my intention is to cover why hands are important, and I hope that it can instill in you some of my passion for hand and wrist anatomy and pathology. What assessment of the hand entails from a medical legal perspective, an introduction to the basic patient-reported outcome measures that I find especially valuable, and then we'll talk through some case examples, which I hope will illustrate some of those points. I've taken some images here from a book that I was gifted by a photographer called Tim Booth, which I would thoroughly recommend. And he's provided a plethora of really beautiful images which demonstrate hand anatomy and hand function from an artistic point of view, and I think illustrate really nicely some of the points that I want to get across to you in terms of what can happen if you experience dysfunction of your hand. Because of course the human hand is an expression of creativity, so we're able to create hugely intricate music through the intricate movement of our hands and wrists, and if we lose those, then that function is lost. And there are a number of people whose professions rely on dexterity, the hand and wrist surgeons, stonemasons, among others. And again, dysfunction in that regard has huge consequences on their personal income, their personal pride, their mental health, their physical health. So these are all important in terms of reporting. Every hand tells a story, and in the image on the left, you're seeing somebody who's able to use their hands in a skillful manner to provide food for their family. And in the image on the right, you're seeing somebody who's worked a lifetime as a coal miner and whose superficial layers of the hand have become stained by the material that they work with. And so in a medical legal assessment, these observations of the state of the hand become important because they tell us a little bit about what a claimant is able to do at the current time. But of course, if your hands are taken away from you, then you lose all of that ability. How do you work? How do you feed your family? How do you eat? How do you conduct basic tasks such as personal hygiene? And the hand is particularly special, certainly in terms of trauma and orthopedics, because it has a huge aesthetic implication. So when you interact with people as humans, you tend to look at their face and you look at the back of their hand. So scars across the back of their hand or deformity affecting the back of the hand are very easily recognized, and they can be very stigmatizing. And claimants often feel under pressure to tell us about pain or stiffness or loss of function. And actually, it's only really when we start to drill down on the aesthetic implications that you understand that the psychology of this injury is really quite huge. When you look at people, you may not notice that their hand has a finger missing, but you'll notice if there's one finger sticking up in the air that doesn't bend, and that's important. So when you appoint your experts, you're looking for somebody who's got a really intricate knowledge of anatomy of the hand, and the anatomy in the hand tends to be fairly constant, and you can predict it fairly well based on surface markings. So this is my hand, and in the image on the left, I've drawn the course of the median nerve, which runs through the forearm and then gives branches to the muscles that supply the thumb, and then sensory branches that go down to the 1, 2, 3.5 fingers. And that's important because your thumb represents probably about 50% of your hand function. So the fingers interact differently. When we talk about hand function, we talk about the need for the thumb to be able to dialogue with the fingers. So if you imagine wanting to talk to 4 people who are sitting on a park bench, then if you position yourself right next to them, your dialogue and your interaction with them will be really quite limited. So you have to position yourself on a separate chair, slightly opposite them, in order to be able to have a conversation with each of those people in turn. And the same is true of hand function. You have to be able to rotate your thumb out of the plane of the fingers in order that it can appropriately dialogue with the fingers and perform the tasks that we ask it to do. The thumb needs to be stable. It doesn't need a huge amount of movement. And that's important as well when we report on hand function, because actually the loss of movement of the thumb, as long as it's stable, is not great. But an unstable thumb can be a disaster because you lose the ability to pinch. These 2 fingers, index and middle, are particularly important for fine motor tasks. So writing, doing up buttons, skilled labor will all employ the interaction between the index finger and middle finger with the thumb. So if the thumb's not able to rotate out a plane and then dialogue with those fingers, you lose the ability to do that. By contrast, the little finger and ring finger are important for power grip. So people who do sporting activities or do heavy work, such as using a hammer, will notice preferentially the loss of function in those two fingers because they're not able to power their grip. So all of these things feed into to how people are affected by loss of function in the hand and wrist. In the image on the right, you see the course of the median nerve and the course of the ulnar nerve. And I show these because we're frequently referred people who have had accidents at work and sustained a penetrating injury to the hand or wrist. And so you can see that if you've got a good understanding of what the surface markings of these structures are, you're able to drill down into what the functional loss might be. If, for example, a Stanley knife that has been used to cut silicon has entered the front surface of the hand, and suddenly they've got sensory change on the fingers that maps the distribution that I've shown with the dotted line here. So that's usually very predictable, and your hand or wrist expert should be able to pick that up quite easily. Similarly, the function and the anatomy of the tendons that run over the hand is very constant. So there are two tendons that power the fingers, and injuries in this area will affect them both. And there are ways that we have for differentiating them on assessment, and you can tell that yourselves. If you isolate a joint by putting a thumb and fingers on either side, then you're using your deep flexor tendon. But that has a common muscle belly, so if you pull on the other fingers, you'll find that only the superficial tendon, the one that splits in two, which I've drawn in the image on the left, is functional. In the image on the right of the screen, I've drawn the surface markings of the joint at the bottom of the thumb. So that joint is called the carpometacarpal joint. And if you have arthritis affecting that joint, then you have essentially base of thumb arthritis. And that's important. That has huge implications, certainly in my medical legal practice, because the incidence of arthritis of that joint in the normal population is huge. And of course, lots of people might have an injury to their wrist and they've not been aware of arthritis in the past, and suddenly it's become painful in the absence of any other obvious defined structure. So your hand or wrist expert, when you appoint them, will need a good working knowledge of the literature so that they can tell you what the incidence of that condition is in the normal population. And they should be able to quote that with references, which we'll talk about. Similarly, you want your hand and wrist expert to have the latest literature at their fingertips so that they can tell you what the natural history of a condition is. If somebody has fallen over and broken their wrist, would we expect them still to have a bit of niggling pain at 6 months? If they have still got a niggling pain at 6 months, should that be gone by 12 months? Or might it take 18 months or 24 months to completely resolve? And that will be important for your prognosis reporting. And our training more recently in hand and wrist has incorporated the ability to study various diplomas in hand surgery, where the relevant literature is taught. And I was lucky enough to be able to complete both a British and a European, which cover slightly different topics and slightly different literature bias. And I found that really helpful for medical legal reporting. We talked about arthritis at the base of the thumb, and it's important when we assess people who come with pain on the radial side of the wrist following an injury to know what the incidence of arthritis is in the normal population. And this was a landmark study from Nottingham, where they took 150 odd people who had had a wrist x-ray done for another reason. So maybe they'd fallen over and hurt their wrist, and the emergency department wanted to know if they had a fracture or not. And they looked back over those x-rays and found that in postmenopausal ladies, 25% of people have isolated arthritis of the joint below the thumb. And then they telephoned them and asked them whether they had pain. And of those who have established arthritis but didn't necessarily know about it because the x-ray was being done for a different reason, of those, only 25% had pain. So that's really important. It's important to understand that 25% of the normal population who have had an innocuous sounding injury will have pre-existing arthritis that's not related to their injury. And of those, only 25% will have pain. And it's only the painful ones who require treatment. So the recommendations become tailored according to the findings on x-ray and the findings on report. So arthritis of the hand and wrist in general is common, but it's frequently not painful. And if you have degenerative change in your hand or wrist, but you're not getting pain from it, then you ignore it. You function completely normally, you do all of your normal hobbies, and you get on with your life. But it can affect you in other ways. Post-injury arthritis can give you stiffness, which can be really quite significant. And it can be disfiguring. And as I alluded to, people don't like that change in symmetry, especially if they're from a culture where people tend to talk a lot using their hands. That will be very noticeable in interactions, and they may find that when they interact with people, that gets commented on, and they don't like the stigma. So what do I see commonly in my personal injury practice? Well, common injuries are common, I suppose, and here's an array of images that we would frequently be asked to report upon. So in the top left, this is a drop finger following a stub injury. Somebody's fallen over, their finger was in a straight position, and now it's bent, and they can't lift it forward. And that's often associated with the X-ray in the middle up here, where the extensor tendon has pulled off a piece of bone, and there's a fracture there going through the joint. So that's a mallet finger. That's common, and we know what happens to mallet fingers in the future, and we're able to report on them very conclusively. Similarly, this X-ray shows a distal radius fracture. This bone is supposed to be straight, and now it's tilted back about 45 degrees. And we know what the treatment for that should be, and we know how that's going to affect the claimant in the future, and we know what types of problems they might develop. And we've got a lot of supporting literature to back us up when we write reports about that. And having that literature to hand is very useful. Some injuries are more subtle, though. You can see down here there's a finger which has got a huge amount of bruising. So that amount of bruising to us suggests a very serious injury. And so if you have claimants who have got photographs from the time of the injury and their date stamped, and you're prepared to accept them, it's really useful when you're asking us to write a medical report if you can send those photographs across, because they give us an idea of what the spread of the bruising is, and therefore what the likely underlying injury is. And we're frequently seeing claimants 9 months, 12 months, 18 months, 2 years down the line from their injury. So to have some kind of pictorial representation of what the finger was like at the time of the injury is really valuable to us. This is a partial amputation. Again, very standard treatments for these, and the post-operative course is pretty well standardized. And then there are some areas where being a specialist in hand and wrist is useful from the point of view of evaluation. So here's somebody who had lacerations over the front of the fingers, seen in the emergency department, closed up, sent on their way. But if you look at the cascade of the hand, so that's the way we describe the resting posture and the resting position, you can see that the index and the middle fingers are bent forward, but the ring finger and the little finger are dead straight. And if you look at your own hand when it's in a relaxed position, that's never the case. So this person's got flexor tendon injuries that have been divided by whatever structure cut the skin. And furthermore, we know from our clinical practice that if that happens, it's very rare that somebody should have that pattern of injury without having cut the digital nerves that run overlying that as well. So an intricate understanding of the anatomy of the hand and wrist plays into the types of injuries that we're then able to report on. I spoke briefly about patient-reported outcome measures, and I find these are really helpful. So these are well standardized, they are validated, they are accepted in hand and wrist research. This is the patient evaluation measure, PEM, and it gives you a score out of 77 dependent on the function of your hand. And I'll come back to talking about that in a second. This is the DASH score, and the DASH score can be used for an injury anywhere on the upper extremity. And when we're reporting on hand and wrist, I would ask somebody to answer it with relevance to their hand and wrist. But here is a series of 21 everyday tasks that somebody might have difficulty with following a hand and wrist injury, and they're asked to score them: no difficulty, mild, moderate, severe, unable. And that's a really useful subjective measure where the claimant has provided us with accurate information about the status of their hand now, on the day that we're seeing them in the clinic, on the day that we're reporting on them. And that is hugely helpful then in being able to report on the current status of their hand. Similarly, the same questionnaire will go into depth on what they're able to do at work, and we'll be able to calculate a score then based on their hand function at work and how it's affecting their sports or arts. And again, we can reference that. So some people might have an injury that doesn't affect them in daily life, but becomes really difficult then when they try to do crochet, or it becomes really difficult then when they try to go to the gym, and that will become apparent from the scoring systems. So let's talk about some case examples now. So this is as a previous mentor of mine once described, this would be considered a slam dunk, I think, in most people's books. So this is a 72-year-old lady who has sustained an isolated ulnar shaft fracture that happened when she was out walking in central London, and she got hit by a van whilst crossing the road. So she sustained an injury not unlike the one that I've represented here, an isolated fracture of the ulnar shaft. And we know how to manage those. She attended her local hospital. She was offered an operation or a plaster cast. She chose a plaster cast. We know what the natural history of that injury is, which is that they tend to be unstable. The ulna will tend to slip back and they'll tend to heal in a slightly altered position. And in some people, that might not affect them functionally at all. But in this lady's case, this really affected her quite significantly functionally. She got pain on the inner border of the wrist whenever she tried to use the wrist, and she had a block to rotational movements because that fracture had healed in an altered position. And so from my point of view, it's very, very clear that that's a fresh injury because, you know, I was provided with the x-rays taken when she attended her local emergency department, and there's no sign of any activity at the bone. So even 2 weeks down the line, I would expect to see a bit of new bone in there, which is not there now. So I know that that's a fresh injury. And then the reporting in terms of the injury she sustained, the prognosis and risk of degenerative conditions is relatively routine. I have a good understanding where it's going to go. I know that she may wish to consider corrective surgery in the future. I know what the costs of that are likely to be and what the outcomes are likely to be as well. That's a relatively clear injury. Of it's not under dispute. She's achieved a suboptimal outcome from her local hospital treatment. Causation is clear, the prognosis is well described, and we know with what the likelihood of degenerative conditions is going to be in this case. But here's one which is slightly more blurred. So this is a 35-year-old man, a right-hand dominant bicycle delivery driver who got knocked off his bike by somebody getting out of an Uber who opened the door into his cycle lane and caused him to go over the handlebars. And I'm grateful to him for giving his permission for me to use these x-rays in teaching. Now, if you look at the front surface of the hand, there's callus here. So if you look at image on the right, the skin here looks subtly thicker, and part of our job when we're evaluating hand injuries is to understand whether a hand is in current use, and the presence of callus on the hand or callus on the foot would suggest that the hand is in regular use and that some load is going through the hand. And that's important because some people may claim an inability to work, some people may claim an inability to perform hobbies or go to the gym. But if they develop callus across the metacarpophalangeal joints here, then that's usually indicative of some kind of vigorous sporting activity, be it using a rowing machine or similar, or lifting weights in the gym. But the claimant nonetheless has sustained an injury. This is characteristic for the type of problem we see if there's been a ligament injury to the front of the finger and it hasn't been managed well. And in the case of this gent, through no fault of his own, he was essentially bounced from one hospital to another. He had his accident fairly far from where he lived, and they tried to refer him to the local hand therapy for a splint, and there was delay in getting that across. So he suffered an adverse outcome as a result of his accident, probably because the institutions treating him didn't get their acting gear at the time. But here are his scores. So he scored 75 out of 77 on his PEM score. Now, in clinical practice, I very, very rarely see a PEM score above 65. So my interest is aroused here because this is an incredibly high PEM score. So that may be that his suffering is greater than he seems to have from my objective assessment. Or it may be that the scores in this case have failed to pick up the subtleties of his suffering. But here's his results on the DASH score, which give him a score of 56%. So it's significantly less problematic on the DASH score. So under these circumstances, when both scores are entered into the report, I make a comment at the bottom here saying that the validity of the PROM scores in this case is called into question because there's conflict between the two scores. And I'm not sure that they're truly reflective of their current level of suffering. So the interesting points from that case are that the appearance of the hand is really important, especially if people aren't able to work or haven't been able to work since the injury, and yet there's still evidence of quite significant load going through the hand at different time points. The patient-reported outcome scores don't always match, and if they don't, then that should draw attention to the possibility of somebody being a bit confabulatory in terms of the way they're reporting their current symptoms. But still, the causation is clear here. This claimant has had an accident and developed a problem that's well recognized as a result of that. And the hand condition has differed slightly subjectively and objectively. So subjectively what they report to me and objectively what I find when I examine them. And so that conflict needs to be reported on, and that will be referenced in the report. This case, which is case 3 of 4, if anybody's worried about needing to check latest football scores, this case is one that's very close to my heart because it represents a real area of interest of mine. So a 63-year-old gentleman who dropped a heavy slab on his hand at work. Now, these are not his x-rays, so we'll look at his x-rays. But the image on the left here shows a normal wrist. So this is the scaphoid bone here, this is the lunate bone, and there's a normal gap between them. Here, between the scaphoid and the lunate, there's quite a significant gap, and that gap shouldn't exist. So that represents a rupture of the ligament that's supposed to hold those two bones together. But there's a good amount of cartilage space here between the radial styloid and the scaphoid. If we look at the image on the right, there's that gap again, but there's wear and tear signs here between the radial styloid and the scaphoid. And so it's clear that there's been quite significant degenerative change here. So time has passed, and as a result of the altered mechanics, this person has started to get arthritis. So I was asked to provide a report. In this case, there have been previous reporting, and the most recent reporter was no longer available on account of ill health. But a number of documents weren't available at the time, so I didn't have the GP records prior to the injury, and I didn't have the documentation from the time of injury when he attended the emergency department, and I didn't have the original x-rays. But this has been quite a significant injury for this claimant. He's not been able to return to work since the accident, and he's undergone a secondary procedure done to evaluate the wrist and look inside the wrist with keyhole surgery. So central in this case to the issue of causation is whether there's pre-existing hand or wrist pain, whether there's been a rheumatological condition, because if you have rheumatoid arthritis or gout, then those conditions can destroy the ligaments, which can give you a similar pattern in the absence of injury. I don't know if there's been a prior injury. I know the information that the claimant has reported to me when we've met, but I would like to be able to corroborate that with the GP records. And in this case, I don't have the GP records prior to the accident. And I don't have the x-rays from the time of the injury. But those were subsequently shared with me. And if you look at these x-rays, it's clear that there's developing arthritis between the two bones. Now that takes months to years to come on. And when I look at the lateral x-ray here, the lunate bone is in extension and the scaphoid bone is in flexion. And that happens as a result of an established ligament injury here, but it doesn't happen on day one because subsequently other ligaments have got to stretch out. Particularly these ligaments down here have to stretch out, and that process takes about 3 months. And we know that relatively reliably. I was lucky enough to be able to contribute a few textbook chapters on similar subjects together with Mike Hayton in Wrightington. So we evaluated all of the literature on ligament injuries and the risks such as this one. And it's clear that that process takes about 3 months. So that x-ray was taken a few days after the accident, and that change cannot be associated with the accident. So when I write the report, it's referenced with the relevant literature, and this injury pattern was described 40 years ago now by Watson, and the set sequence of arthritis that happens is well recognized in the hand surgery community. So this is relatively uncontroversial for us. But it means that from the point of view of causation, arthritis is present at the time of injury. There's what we call a dizzy deformity, dorsal intercalated segment instability, where the two bones have tilted into the wrong position on the lateral x-ray. So it's my opinion that the accident cannot be causative on balance of probabilities in this case. But it might have been precipitant, so the claimant had no pain up until the point of the accident and suddenly they've had pain. Or it might be accelerant, so they had a bit of pain but it wasn't that bad, and now suddenly the pain has come on with a vengeance. And to understand that, I need the GP records. So I'll need to know whether they've ever visited their GP for hand or wrist pain and what the nature of that has been. This is not a hand and wrist case, but it did raise some interesting points for me, and I wonder if I can therefore beg your indulgence. I was asked to report on a 75-year-old gentleman who was hit from behind whilst driving. They carried a psychiatric diagnosis, which was quite significant. They'd attended hospital on the day of the injury and they complained of pain in the knee. And then when they came to see me in the clinic, they had very significant pain in the knee. Now, they told me that their crutches had been left in the vehicle outside, and they walked with a very stiff knee. But it was interesting that when we started the interview, the knee was able to relax actually, and they were able to achieve quite significant bend, sort of normal bend that you might have sitting on your chair now in the order of 90 degrees. When it came to time to examine the knee, though, the knee was rigid again, and I couldn't get this knee to relax for examination, which really precludes the ability to do a decent examination. But when reviewing their medical records, in actual fact, they'd attended their emergency department complaining of pain in the opposite side. So it wasn't the knee that had been painful at the time that was still painful now. And I don't know how to reconcile those two pieces of information. I don't know under what circumstances somebody might attend with a problem related to the left knee and then 18 months after, when coming for assessment, have trouble with the right knee. And I don't know under what circumstances they might be able to relax the knee sitting in a chair whilst being spoken to and then hold it dead straight for examination. But it's certainly my experience in clinical practice that that's unusual. And so in my report, I have to raise the possibility of non-organic or functional disorder. So these are not necessarily pathologies related to the knee joint themselves, but it may be to do with the interaction of psychology and the joints that has caused a dysfunction here. And I would raise the possibility of malingering. So I'm not an expert in the assessment of fundamental dishonesty, and it may be that the psychiatric diagnosis has an implication here. But it's certainly my job to report on inconsistencies as I see them and flag up anything that could be considered of that nature. So this person had had lots of previous road traffic accidents and previous claims. They hadn't been able to attend their hospital follow-up on account of their psychiatric diagnosis. And this is a limb that fluctuates in terms of examination findings with distraction. And so that may be psychologically driven, and it may be fundamental dishonesty. So in my report, I would recommend a psychiatric evaluation in that case. So in summary, the hand is a complex organ. Your expert needs to have an understanding of anatomy, of the natural history of the injury, and of the evidence that governs our specialty, and especially the evidence that governs prognosis reporting. The imaging from the time of the injury and any clinical photographs are really paramount for us to understand exactly what the diagnosis is, and then essential to the issue of causation. And degenerative conditions are common, but they're not necessarily symptomatic, and that can be reflected in the quantum that you seek. And so it's important that your expert gives you an understanding of that as well. So I think that's everything that I wanted to talk about. But if people have any questions, then I'll try and go through them as they come up.
Well, whilst people might be asking some questions in the Q&A function, one thing which did come to mind, which I wanted to raise, is is whether it would be helpful from your perspective to ask the claimant to keep a diary of their symptoms in relation to what they can and they can't do and the changes throughout following the injury, and would that be of value to you when assessing?
Yeah, that's of huge value actually, and part of my discussion with the claimant before we start the interview is that when they go to see a doctor, the doctor is interested in diagnosis and treatment. But when they come for an expert witness assessment, we're really interested in pain and suffering, because primarily that's what the court will be interested in. And it's often difficult for claimants because they're used to coming to see the doctor. They come and see me in a GP practice, which is where my rooms are based. And so it's a very clinical environment. But actually, the questions that I'm asking are hugely different. I want to know, how long did you have severe pain? And then at what point did the pain become moderate? And can you score it now out of 10 at rest? And can you score it out of 10 with activities? And these are questions that they just haven't been asked in the normal logical treatment of their condition by somebody trying to make them better. But in somebody who wants to report on the condition of their hand and wrist, that's of fundamental importance. So it's really useful in the letters that go out to them that they can be warned that, the style of questions are going to be slightly different. And if they can start to have a think about, because often we're 18 months down the line. So if you had your injury in January 2022, then how long was that wrist painful for? And when did it become bearable again? And when did you have to stop taking painkillers? And when could you go back to cycling? And when could you go back to driving a car? Well, 18 months down the line, people have forgotten all this. So it's very useful if they can be prompted before coming to the assessment, so that when we enter that data into our report, it's 100% accurate.
Yeah. Thank you very much, Mr. Wharton. We have another question here, although from Lucy, although it's relating to clinical negligence, and I appreciate that that's not an area which you comment on. So, I mean, I can ask you the question, but I don't know whether that falls within your remit at this point.
You're welcome to ask. We're a very small community in hand surgery, and so I haven't.
Your current position is not to be commenting on those matters.
Yeah, there aren't so many people that I don't know.
Well, in terms of
ask your question.
The question is, Lucy asked, in terms of clinical negligence claims, would a delay in diagnosis and treatment of a tendon injury be causative, or do patients do well even with a late diagnosis of tendon injury, or is this case dependent?
Yeah, so I can answer that question from the point of view of when people come to see me in the clinic, and they're often interested in the same thing. So the most common wrist ligament injury that we see is probably the scapholunate ligament injury, and that's the ligament that we talked about in this case. So that tends to happen when a significant violent force has gone through the wrist, usually with the wrist in an extended and supinated position. So it's that kind of force going through. So if that injury is known about at the time, then a number of treatment options might be available. And they could include an acute repair of the ligament, or they might include a plaster cast, or they might include no treatment. And that is patient dependent. If you're seeing somebody more than 6 weeks down the line and they've had an acute tear of the scapholunate ligament, then you would be worried that the ligament's starting to shorten. And at that point, doing an acute repair certainly becomes more challenging, and the outcomes are probably not as good. And so then you look at other techniques, ligament reinforcement, and there are some commercially marketed products available, or a ligament reconstruction, such as taking a third of the tendon that runs down the front of the wrist, drilling that through the bone and reconstructing the ligaments that way. And again, we are fairly confident when we report what the natural history of that operation is, because the group in Wrightington had reported 163 wrists where this procedure was done, and we know roughly how many people go back to work and how many people have pain. If you're down the line to the point that somebody started to develop arthritis, and that's really variable as to what time that happens. We know it will happen eventually, but we don't know when. It can be months, or it can be years, or it can be decades down the line. So if you're at a point where you've started to develop arthritis, then the treatment options shift, and they might include more damage control stuff. So start trying to avoid surgery in the first instance, splints, hand therapy, steroid injections. And then if they get to the point where they're at the end of their tether, then we consider basic tying over operations, or tiding over operations, such as taking away the branches of nerves that supply the joint with pain, but that's not going to affect the underlying arthritis, but it make the pain better. And then more destructive things such as taking bones out, or doing partial fusions, or completely fusing up the wrist. So the timing of the patient's presentation is of paramount importance when we see them as the treating doctor. From a negligence point of view, I don't know what the implications are there, and it's probably a case-by-case discussion, I would have thought.
Thank you very much. Here, we've got one from Jason Harries, and he has asked, to what extent will a hand surgeon deal with a pain condition, CRPS, secondary from trauma, or is that a matter that you'd pass to a pain expert?
No, not straight away. So eventually, yes, and the management of pain should always be multidisciplinary. So having hand therapists, hand surgeons, and pain experts all involved in the treatment of that condition is really helpful. CRPS is complex regional pain syndrome. So this is a phenomenon we see in the hand and wrist after injury or after surgery. It's difficult to predict who might get it. We know it's more common in ladies and it's more common in the elderly. And its management is really challenging because we don't know, the procedure might have gone perfectly, or their recovery from the injury ostensibly might have gone perfectly, but they've got pain that we can't explain. So from a surgical point of view, we want to understand, has there been a nerve injury here? Because CRPS is divided into those who have a defined nerve injury and those who don't. And if there's a nerve injury, then going in and repairing the nerve can be a benefit for pain. Similarly, if the nerve has just been stretched and there's a lot of scar tissue around it, then taking away that scar tissue surgically can be really beneficial for pain.
Sorry, carry on? I was just going to say, but if you can also comment from a medico-legal perspective, would you see yourself as commenting on that in a report, or some of that, or would you say you would be doing it, or you'd say you'd pass that from a medico-legal perspective to the pain expert?
It's a routine part of my assessment, is a comment on whether or not the claimant has suffered complex regional pain syndrome. And there will be features when you examine the hand. There may be excess sweating, there may be no sweating at all. They may have color changes, and they'll often have photographs on their phone of what the different color changes are, because of course when you go to see somebody, the color changes are never present. So I would include a routine comment on the presence or absence of CRPS. I think that's really important for condition reporting in hand and wrist expert witness statements. Yeah.
Oh, brilliant. And here, another question. If you get a case which requires further x-rays, do you do them? And I think what Vanessa is referring to, are these done at the medical immediately, or would you report, send away and request further x-rays to review at a further date?
Yeah, no, I would never do them straight away. They are a recommendation, and there's obviously a cost associated with that. It's a low value claim that can have quite significant implications. If you start recommending not just x-rays but MRI scans, that can have quite significant implications on the cost of the whole process for the claimant. And the other factor is that sometimes people are uncomfortable about having further x-rays. So I recommended a follow-up x-ray and MRI scan recently for a claimant, and their litigation friend actually got in touch and said, this sounds like quite a lot of radiation. So in actual fact, MRI scans don't carry a radiation burden. They don't involve radiation at all. A CT scan would, but an MRI scan doesn't. But I think if we'd just gone ahead and ordered a test without that being validated, then you know, the litigation friend would have called that into question. So no, I would never organise tests without the instructing solicitor and the claimant being on board with that.
No problem. And there is a follow-up from Lucy in regards to that clinical negligence question. But Lucy, if I may, we can pass that off to a further date outside of this, and I'm sure Mr. Wharton would be happy to perhaps fill you in on that if you wanted to send an email or have a quick chat with him at a later date. As I appreciate this is more about the personal injury perspective today, and we are coming closer to the end of our hour, and I don't want to keep everyone waiting after their lunch is finished. So just finally, oh, hold on. Here you go. Yes, sorry, Paul has just asked a further question. Do you include costings for any recommended surgery in your report as standard? Do you do it when requested? How do you work with costings in your reports?
Costings when requested, it's not especially difficult to add them in if you would like them. I don't put them in routinely because I have done in the past, and then I've been asked to take them out. I think that I'm not sure what the rationale was actually, but that solicitor wanted them removed. So I no longer put them in routinely, but if in your instruction you request them, then I would put them in routinely, yes. Yeah, so I tend to cost the cost of a splint, the cost of follow-up for the splint, when they would need to be seen again by the hand therapist for adjustment to the splint, the cost of x-rays, and the cost of the various procedures that might be an option for that person in the future. Yeah.
Brilliant. Well, thank you very much, Mr. Wharton. I think we've covered all the questions there. That's been incredibly informative, and I'm sure I speak on behalf of everyone to say a big thank you for giving us your time today to talk to us. So we really appreciate that.
Yeah.
And just to advise everyone, look, Mr. Wharton is open and able to comment on your personal injury matters relating to hand and wrist particularly. It's his specialist area.